Yeah, I'm sorry for the interruption, but really I missed that the session was ending. We were discussing a case of angioedema or facial swelling. You will find also a lot of theoretical description of this case in the book, but this was a real exam case. And from the history, she was a lady working in a cosmetic shop. So she was always in contact with creams, as she was always trying the creams for the customers and so on. And then there was some stress in the family. And she gave also history of appendectomy in the past history, just to make you put more in the differential diagnosis. And why? Because patients with Henoch-Schönlein purpura also can have appendectomy and abdominal pain and so on. Appendectomy secondary to abdominal pain, which might be undiagnosed at the start. So also from the history, family history, she was adopted. And also there was, in another scenario, there was a history of familial Mediterranean fever, and there was also a history of angioedema. So different scenarios can come from this case. And abdominal pain and facial swelling. You can have a lot of cases, you can have a lot of differential diagnosis, and you can only explore this by history taking. In endocrinology, a very important topic in real practice, in everyday practice, and also in the exam is hypoglycemia in non-diabetics. Mr. Meher Radwan is a 24-year-old gentleman presented with weight loss and found to have hypoglycemia. Please examine and advise. So there are a lot of differential diagnoses in this case. So before start discussing with the patient, you have to set a sensible differential diagnosis. And for the causes of hypoglycemia in non-diabetics, I also put a new monomer, which is called explain. EX stands for exogenous insulin or oral hypoglycemic drugs. P stands for pituitary causes. L stands for liver disease, a chronic liver disease or chronic renal failure. A stands for alcohol and quinine, and also stands for adrenal insufficiency. I stands for insulinoma, and N stands for non-insulin secreting tumors. In stable patient, there is another. In unstable patient, there is another differential diagnosis, which could be sepsis, but usually the exam case is a stable case. What about if this patient is diabetic and he's suffering from frequent hypoglycemia? First, in diabetics, there are three main items for differential diagnosis. First, like in non-diabetics, you have to also exclude the explain, because he is a normal person. He can have pituitary disease, he can have liver disease, he can have renal disease, and so on. Especially with renal disease, if the patient is taking oral hypoglycemic drugs, they are not excreted in the urine, so the half-life is very prolonged, and the patient will suffer from repeated attack of hypoglycemia. So if hypoglycemia occur in diabetic, don't forget also to exclude the same causes of in non-diabetics, plus also the usual causes like he took his insulin and he did not take his meal and so on. So the usual causes, يعني lack of rotation of the needle and so on, the usual causes that can happen in any diabetic, or wrong dose, wrong route, not rotating the needle, taking the excess dose because of retinopathy and so on. So you can deal with it as a case of usual causes that we are all facing in everyday activity and everyday practice. But also remember to ask about the monomer explain that we have already explained in the previous slide, and also to ask about pancreatitis, recent attack of pancreatitis that may worsen his diabetes and reduce the amount of insulin secreted from the pancreas, the association of diabetes and pancreatitis with cystic fibrosis, the hemochromatosis with its affection and filtration of the pancreas, and also drugs causing hypoglycemia. So this is the end of this talk and the end of our lectures today. My advice for you is always have a discussion plan. Keep important differential diagnosis in mind and have a roadmap. Study important scenarios because what's common in the scenarios is common in the real life. And what's common in the scenario is common in the scenarios. Thank you very much. And thank you for listening and hope to see you in the next talks. And please, if you have any questions, please start to ask now.
شكرا يا دكتور، شكرا.
العفو العفو، وإن شاء الله بإذن الله احنا نحاول إن شاء الله النهاردة نرجع نقرأ الكلام دوت ونحاول نحفظ على قدر الإمكان اللي هي السكيم اوف هيستوري تيكينج. وإن شاء الله بإذن الله السيشنز الجاية تكون interactive and I hope if we can prepare any interactive session يعني في قاعة المحاضرات ونبقى كلنا مع بعض، ويعني ندي سيناريو، ندي واحد فيكم ان هو يكون هو الكانديديت، واحد فيكم هو السيروجيت، ونبدا نشوف ازاي هنفكر، ازاي how to approach this case and how to make a sensible differential diagnosis. ومع بعض هنراجع مع بعض شويه الانفستيجيشنز والمانجمنت اوف each case. فيا ريت يكون في ان شاء الله باذن الله كده، يعني I have a lot of scenarios. الحقيقه في الكتاب بتاع الهيستوري The Art of History Taking بتاعي في حوالي 127 سيناريو، وكل سيناريو محطوط معاه الكلينيكال باك جراوند بتاعه عشان ما نحتاجش نقرا من بره يعني. لكن في سيناريوهات كتيره برضو عندي بره الكتاب، ممكن ان شاء الله باذن الله نبقى نوزعها ونبدا ان شاء الله نشتغل عليها ونعمل تريننج، ويا ريت ده يكون متاح يعني. فيعني اتمنى من الله سبحانه وتعالى ان انا اشوفكم دايما على خير.
بإذن الله يا دكتور، شكرا لحضرتك جدا. شكرا.
شكرا ليكم واشوفكم دايما على خير ومع الف سلامه.
مع السلامة.